Dear doctors, in today's video, I will present different set of questions on infections and antibiotics related to EDIC Part 1. So let's begin.
Question 1. A 70 kilograms man with septic shock and acute kidney injury is receiving meropenem. Which dosing strategy best optimizes antibacterial efficacy? Single daily bolus dosing. B. Standard 8-hourly bolus dosing without adjustment. C. Prolonged infusion over 3 hours every 8 hours. D. Continuous infusion at a lower total daily dose. Once daily dosing guided by trough serum levels. Correct answer is C. Prolonged infusion over 3 hours every 8 hours. Explanation. Meropenem, a beta-lactam, is time-dependent antibiotic, so efficacy depends on the time above minimum inhibitory concentration. Prolonged or continuous infusion improves exposure in critically ill patients with altered pharmacokinetics. Bolus or once-daily dosing reduces efficacy. Continuous infusion is also effective but requires stable access and drug stability. Standard of care often favors prolonged intermittent infusion. Question 2. A 55-year-old ventilated patient develops fever, purulent secretions, and a new infiltrate after 8 days in ICU. Which of the following statements about ventilator-associated pneumonia is most accurate? Early VAP, less than 2 weeks, is more likely due to sensitive organisms. B. Quantitative bronchoalveolar lavage cultures are always superior to endotracheal aspirates. C. Empiric therapy should include broad-spectrum coverage, tailored to local antibiogram. D. VP prevention is primarily achieved with prophylactic antibiotics. Diagnosis requires positive blood cultures in addition to radiological findings. Correct answer is C. Empiric therapy should include broad-spectrum coverage, tailored to local antibiogram. Explanation. Early ventilator-associated pneumonia is usually due to community flora. Late VP is more MDR-prone. But they are defined as early if it occurs within the first 4 days of invasive mechanical ventilation and late if 5 or more days after initiation of invasive mechanical ventilation. Bronchoalveolar lavage fluid cultures may improve specificity but are not always superior. Endotracheal aspirates are widely used. Prophylactic antibiotics do not prevent EP. Moreover, risk of resistance increases. Diagnosis does not require bacteremia. It is clinical plus radiological plus microbiology based. Question 3. A 45-year-old immunosuppressed man, renal transplant, on tacrolimus, is admitted with fever, cough, hypoxemia, and bilateral ground glass opacities on CT. PCR from bile fluid is positive for CMV. Which is the most appropriate treatment? A. High-dose acyclovir. B. Ganciclovir intravenous. C. Oseltamivir. D. Ribavirin. Reduction of immunosuppression alone. Correct answer is B. Ganciclovir intravenous. Explanation. CMV pneumonitis in immunocompromised patients requires intravenous ganciclovir or valganciclovir orally if mild. Acyclovir is active against herpes simplex or varicella zoster virus, not CMV. Oseltamivir is for influenza. Ribavirin is used for respiratory syncytial virus and some hemorrhagic fevers. Immunosuppression reduction is important but not sufficient as monotherapy. Question 4. A 65-year-old man with diabetes and chronic kidney disease presents with septic shock secondary to perforated diverticulitis. He is on norepinephrine infusion, 0.3 microgram per kg per minute, and has received broad-spectrum antibiotics. CT abdomen shows a large pelvic abscess. His lactate is 5 millimoles per liter, and urine output is minimal despite fluids and vasopressors. Which of the following is the most appropriate next step in management? Escalate vasopressors and delay intervention until hemodynamics stabilize. B. Perform percutaneous abscess drainage as early as possible. C. Continue antibiotics alone and repeat imaging after 48 hours. Start high-dose corticosteroids to control inflammation before surgery. Initiate renal replacement therapy prior to drainage. Correct answer is B. Perform percutaneous abscess drainage as early as possible. Explanation. Source control is essential in abdominal sepsis and should be performed as early as possible, even in patients on vasopressors. Delaying drainage for stabilization worsens outcomes. Antibiotics alone are insufficient when a drainable focus exists. Steroids are not indicated for source control. Renal replacement therapy may be needed but should not delay urgent source control. Question 5. A 59-year-old woman with decompensated cirrhosis is admitted to ICU with septic shock. She has been hospitalized twice in the last 3 months and has received several courses of broad-spectrum antibiotics, including meropenem. She now develops blood cultures growing Klebsiella pneumoniae, with resistance to carbapenems, fluoroquinolones, and aminoglycosides. Susceptibility testing shows resistant, meropenem, ciprofloxacin, gentamicin, cefepime. Sensitive, tigecycline, ceftazidime-avibactam. Also, aztreonam tests susceptible, but the strain is known to produce an NDM metallobeta-lactamase. Which of the following treatment regimens is most consistent with the recent IDSA guidance recommendations? Tigecycline monotherapy at standard dose. B. Ceftazidime-avibactam monotherapy. C. Ceftazidime-avibactam plus aztreonam combination therapy. D. Colistin plus high-dose tigecycline combination therapy. Meropenem plus colistin combination therapy. Correct answer is C. Ceftazidime-avibactam plus aztreonam combination therapy. Explanation. The latest Infectious Disease Society of America guidance on AMR gram-negative infections indicates that for CRE infections, especially those caused by metallobeta-lactamase, for example NDM, VIM, IMP, producing strains, the combination ceftazidime-avibactam plus aztreonam is recommended. Newer beta-lactam, beta-lactamase inhibitor, BLBLI, combinations, such as ceftazidime-avibactam, meropenem-vaborbactam, imipenem-relebactam, are preferred when there is in vitro susceptibility. Aztreonam is resistant to hydrolysis by metallobeta-lactamases, so when a CRE strain produces NDM, a metallobeta-lactamase, ceftazidime-avibactam alone will not be sufficient because avibactam does not inhibit metallobeta-lactamases. The addition of aztreonam addresses this gap. Alternatives, like colistin combinations, are considered when newer BLBLI agents are unavailable, but they are not first choice when safer, more effective newer options are accessible. Question 6. A 42-year-old farmer from Southeast Asia is admitted with 7 days of fever, severe myalgia, jaundice, and oliguria. On day 3 in ICU he develops acute hypoxemic respiratory failure requiring intubation. Labs. Total bilirubin, 12 mg per deciliter, creatinine, 4.2 mg per deciliter, platelets, 45,000. Chest X-ray, bilateral alveolar infiltrates consistent with pulmonary hemorrhage. Which of the following is the most appropriate therapy in addition to organ support? High-dose penicillin or ceftriaxone. B. Intravenous acyclovir. C. Intravenous artesunate. D. Meropenem. E. Intravenous corticosteroids as monotherapy plus platelet transfusion. Correct answer is A. High-dose intravenous penicillin or ceftriaxone. Explanation. This patient most likely has severe leptospirosis, Weil's disease, complicated by jaundice, renal failure, thrombocytopenia, and pulmonary hemorrhage or ARDS. Intravenous penicillin or ceftriaxone is the treatment of choice for severe leptospirosis in ICU. Corticosteroids are sometimes used as adjuncts in pulmonary hemorrhage, but never as sole therapy. Question 7. A 62-year-old man with obesity, BMI 34, type 2 diabetes, and ischemic heart disease is admitted with severe COVID-19 pneumonia. Day 5 in ICU. He is intubated for ARDS. Partial pressure of arterial oxygen to FiO2 ratio equals 70 on FiO2 0.85, PEEP 14. On norepinephrine 0.2 microgram per kg per minute for septic shock. FiO2 requirements are rising despite prone ventilation. Chest CT, Bilateral ground glass opacities with areas of consolidation. Labs. CRP, 280 mg per liter, ferritin, 2,300 microgram per liter, D-dimer, 4.5 microgram per milliliter, IL, 6 markedly elevated, procalcitonin, 0.3 nanograms per milliliter, blood cultures, negative at 48 hours. The ICU team is debating escalation of therapy. Which of the following strategies best aligns with current evidence and international guidelines? Escalate to high-dose methylprednisolone, 250 mg per day, for cytokine storm. B. Continue standard dose dexamethasone and add IL-6 receptor inhibitor, tocilizumab, given inflammatory profile and early ICU course. C. Add remdesivir since the patient is on invasive ventilation and hypoxemic. D. Initiate therapeutic dose anticoagulation empirically because of high D-dimer. Start broad-spectrum antibiotics routinely to prevent ventilator-associated pneumonia. Correct answer is B. Continue standard dose dexamethasone and add IL-6 receptor inhibitor, tocilizumab. Explanation. Dexamethasone 6 mg per day is the established first-line therapy in severe or critical COVID-19. IL-6 inhibitors, for example, tocilizumab, saralimab, improve outcomes in selected patients with rapid clinical deterioration, high inflammatory markers, and early ICU admission, as in this case. High-dose steroids have no proven mortality benefit and increase infection risk. Remdesivir shows little benefit once patients are ventilated. Benefit is seen mainly in early or moderate disease. Therapeutic dose anticoagulation is not routinely recommended in ICU patients. Standard prophylaxis is advised unless thrombosis is confirmed. Empiric antibiotics are discouraged unless there is evidence of bacterial co-infection. Low procalcitonin here supports viral process. Question 8. A 48-year-old man with a history of type 2 diabetes is admitted to the ICU with fever, chills, and shortness of breath for 2 days. He recently had a central venous catheter placed for chemotherapy. On examination, temperature 39.6 degrees Celsius, BP 85/50 mmHg, heart rate 130 per minute. New systolic murmur heard at the mitral area, multiple small erythematous nodules on fingertips, lungs, scattered crackles. Labs, WBC, 20,000, platelets, 80,000, CRP, 220 mg per liter. Blood cultures, gram-positive cocci in clusters. Which of the following is the most likely causative organism? Staphylococcus aureus. B. Streptococcus pneumoniae. C. Enterococcus faecalis. D. Pseudomonas aeruginosa. E. Neisseria meningitidis. Correct answer is Staphylococcus aureus. Explanation. This patient shows classic Staphylococcus aureus bacteremia with infective endocarditis, fever, new murmur, oscillar nodes. Recent central venous catheter placement is a major risk factor for Staphylococcus aureus bacteremia. Blood cultures show gram-positive cocci in clusters, consistent with Staphylococcus. Streptococcus pneumoniae typically causes pneumonia and meningitis but not catheter-related bacteremia with endocarditis. Enterococcus faecalis can cause endocarditis but usually in older adults or urinary tract sources. Pseudomonas is gram-negative and usually affects immunocompromised hosts or ventilated patients. Neisseria meningitidis presents with meningitis or septicemia, often with purpuric rash, not endocarditis.
Dear doctors, I am sure these questions will be useful to you during your EDIC Part 1 exam. If you have any feedback, suggestion or comments, or if you want to discuss any question or answer, please write in comment section box where I will respond.